It is my honor to present the topic of progress of biodegradable stents in China at the 19th China-German Cardiovascular Forum. And as we all know, BRS is almost dead in the rest of the world except China. This kind of device is still alive and popular to our patients. By 2020, 2 BRS have been approved by Chinese FDA. More of them are currently in clinical status. And I will show you latest clinical results of these devices. Of course, I will focus on SYNSOP scaffold, which I was most familiar with, and then give brief introductions to other BRS. The first BRS I would like to introduce is the SYNSOP scaffold. The SYNSOP scaffold was the first BRS involved in clinical study in China. The scaffold was composed of PLLA as its platform and coated with PDLLA. Sirolimus was used as its anti-proliferative agent. About 80% of the drug was eluted in 1 month. The thickness of the struts was 160 micrometers. The scaffold was expected to be total absorbed in 2 to 5 years. The SYNSOP first-in-human study was carried out in September 2013 through January 2014, led by Professor Junbo Ge at 2 sites in China. The primary endpoint of the study was in segmental late luminal loss at 6 months after the index procedure. The safety endpoints were MACE at 30 days and 6 months after the index procedure. Total 30 patients with stable clinical conditions and simple to moderate complicated lesions were finally enrolled. The QCA results of film study at 6 months showed promising results of late luminal loss at 0.18 millimeters, similar to that of a traditional metallic DES. Up to now, we have completed 5 years of clinical observation. As we can see, the rates of TRF and MACE were 13% and 16% respectively. More importantly, no events were recorded beyond 2 years of follow-up. The struts were completely absorbed at 5 years on the OCT. Considering no optimal implantation technique was introduced at that time, BRS was used just as a traditional metallic DES stent. A slightly higher rates of TRF and MACE were acceptable. The SYNSOP RCT study was designed as a prospective, randomized, multi-center trial to examine whether SYNSOP scaffold was non-inferior to a sirolimus eluting metallic stent. Enrolled patients were randomly assigned to SYNSOP-treated group or DES-treated group at 1-to-1 ratio. The primary endpoint was 12 months late luminal loss. All enrolled patients were regularly followed up at scheduled time. 200 patients for SYNSOP and 195 patients for DES were finally enrolled. At 1 year, more than 80% of patients were angiographically followed up in both groups. Almost all patients were clinically followed. Baseline information of demography were well balanced in both groups, like male, gender, risk factors, clinical conditions, and lesion level data. As we can see, per protocol, relatively simple to moderate complicated lesions like ACCHA type A or B1 were mostly treated. Predilation and postdilation were more frequently performed in SYNSOP group because predilation and postdilation were mandatorily required in SYNSOP group, but just recommended in DS group. Here shows the QC results. Baseline RVD, MLD, and percent DS were balanced between groups. Post-procedural MLD, percent DS, and acute gain were similar with both devices. There were 5 wrist stenosis cases in DES-treated patients. No wrist stenosis was detected in SYNSOP group, both in device late luminal loss and in segmental late luminal loss of DES were higher than those in SYNSOP group. The primary endpoint of 12 months in segmental luminal loss was 0.19 millimeters in SYNSOP versus 0.31 millimeters in DES. As a result, up confidence limit of above difference was minus 0.12 millimeters, which was below the non-inferiority margin. There were 93% of SYNSOP-treated patients and 92% of DES-treated patients were clinically followed up at 5 years. There were no significant difference in clinical outcomes in SYNSOP and DS groups, including TLF, cardiac death, pocket vessel myocardial infarction, and IDTRI. Rate of definite device thrombosis in SYNSOP-treated patients was only just 1%. Furthermore, no thrombosis occurred beyond 2 years of SYNSOP BRS implantation. Different to ABSORB study, DAPT was still carried on in more than 50% of patients in both groups. That may partly explain why there's a better clinical results in SYNSOP BRS than BVS. Here we come to a Neovasc scaffold. So design of Neovasc was quite similar to SYNSOP BRS. PLLA was used as platform. PDLLA with sirolimus was coated on the struts. The thickness of the coating was 5 micrometers, with the dosage of sirolimus was 15.3 microgram per millimeters. Results of Neovasc FIB study show that only one case of wrist stenosis was revealed at 6 months follow-up. In segmental late lumen loss was 0.25 millimeters. Almost all struts were covered on the OCT test. The design of Neovasc RCT was similar to SYNSOP BRS. Total 567 patients were randomly assigned to Neovasc treated group or Xience treated group at 1:1 ratio. Almost all patients were clinically followed up at 3 years. The performance of Neovasc was promising. The rates of TRF and stent thrombosis were relatively low and favorable in both groups. It was believed that optimal implantation technique like PSP may improve clinical outcomes BRS. Relatively small vessels whose diameter less than 2.25 millimeters was an independent risk factor of TRF. Compared with ABSORB 2 and ABSORB 3 studies, less than 8% of small vessels were treated with Neovasc BRS, leading to a lower rates of TRF and scaffold thrombosis in Neovasc RCT study. And iron was suggested as an alternative bioresorbable metal to magnesium in scaffolds. Iron is biodegradable, has a strong radial force, and plays a vital physiological role in human physiology. IBS is consisted of an ultra-thin nitriding iron backbone with a zinc submicron layer coated with PDLLA, incorporating sirolimus. In posing studies, biocorrosion did not occur before 6 months, and the stress coverage was more rapid than the everolimus eluting stent. Other vascular responses were similar. So the IBS has a set of radial plaque markers at proximal and distal ends. The iron strut was coated with a zinc buffer layer first, and then a symmetric PDLLA coating with sirolimus was sprayed, with most of antiproliferative drug on the abluminal side of the IBS strut. The strut thickness was about 70 millimeters. IBS film was a prospective single-arm open-label trial that enrolled 45 patients from Fudan Hospital in Beijing to acquire serial intravascular imaging information at different intervals. The population was randomly divided into 2 cohorts in a 2:1 ratio. The 30 patients randomized to cohort 1 was assigned to undergo imaging follow-up at 6 months and 2 years, and the rest of 15 patients randomized to cohort 2 were assigned to undergo follow-up imaging at 1 year and 3 years. Assessment using IVUS and OCT was performed post-procedure and at each the angiographic follow-up time points. Baseline the post-procedural QC results were similar between the 2 cohorts. Acute recoil was just 0.12 millimeters. Angiographic follow-up was completed in 100% patients at 6 months and 12 months, in 75% of patients at 2 years, and in 47% of patients at 3 years. In scaffold late luminal loss was 0.33 millimeters at 6 months, 0.39 millimeters at 12 months, 0.40 millimeters at 24 months, and 0.37 meters at 36 months. Vessel motion did not change from 6 months to 3 years. All patients completed follow-up up to 3 years, and 4 patients underwent TLR, 3 of which were clinically indicated. 1 patient experienced chest discomfort at 6 months post-procedure. Angiography showed in-scaffold wrist stenosis in the middle LAD, and the patient underwent TLR with a metallic DES. 2 patients with recurrent angina and wrist stenosis noted at 12 months angiographic follow-up and underwent TLR. Thus, the rates of TRF were 2.2% at 6 months and 6.7% after 1 year. One additional patient underwent a non-TRR target vessel revascularization. There were no deaths, myocardial infarctions, or scaffold thrombosis up to 3 years follow-up. Strut coverage was rapid, and no strut fractures or late acquired malposition was observed. The rate of strut resorption steadily increased from 34% at 6 months to 95% at 3 years, without malposition during the bioresorption process. The BRS is now at RCT status. The last BRS I would like to note is Firesol BRS. Firesol BRS is a balloon expandable, highly crystallized PRRA backbone scaffold system, abdominally coated with PDRA mixed with sirolimus, using highly accurate and precise point spraying techniques. The thickness of the Firesol BRS is 100 micrometers for scaffolds, 2.75 millimeters in diameter, and 125 micrometers for scaffold for 2 to 4 millimeters in diameter. Both ends of the scaffold have one radiopack marker. The backbone is designed to be absorbed within 2 to 3 years. The Future One study trial was a prospective, open-label, single-center, first-human study. After BRS implantation, patients were randomized into 2 follow-up cohorts in a 2-to-1 ratio. So 30 patients in cohort 1 were required to undergo QCA, IVUS, and OCT post-procedure and at 6 months and 24 months, while the rest 15 patients in cohort 2 underwent the same evaluation post-procedure and at 12 and 36 months. The clinical follow-up was performed by clinical visit at 1 year and by telephone or clinical visit at 1 and 6 months, and annually thereafter up to 5 years. Baseline and post-procedural QC measures were balanced between 2 groups. Acute recoil was 0.12 millimeters in overall cohort. Angiographic follow-up was available in 29 patients at 6 months and 26 patients at 2 years for cohort 1, and in 40 patients at 1 year and 10 patients at 3 years for cohort 2. In scaffold, MLD decreased significantly from 6 months to 2 years follow-up. Both in scaffold and in segmental MLD, late lumen loss, and other QC endpoints followed a similar trend. So vessel motion showed a numerically increase during the 3-year follow-up. And here is the IVUS measurements were available for 29 patients at 6 months and 14 patients at 1 year, 25 patients at 2 years, and 10 patients at 3 years. The mean or minimal vessel and scaffold area was stable during follow-up. The mean or minimal luminal area decreased over the 3-year follow-up. Changes were more prominent from 6 months to 2 years than from 1 to 3 years. And OCT measurements were available in 29 patients at 6 months follow-up, 14 patients at 1 year, 25 patients at 2 years, and 10 at 3-year follow-up. No post-procedural fracture was observed. The mean luminal area decreased from 6 months to 2 years follow-up, but remained stable from 1 year to 3-year follow-up. Strut level analysis revealed proportion of covered struts as high as 99.7% and 99.8% at 2 and 3-year follow-up. No persistent malposition was observed. Healing score and the mean black hole area significantly decreased over time, and more than 95% of struts had a different morphology of resorption by OCT. And here's the conclusion. We think BRS is still welcome and popular in China. Patients like something nothing left in their bodies. Companies need new growth in market sales and business maps. And as to our doctors, we need a novel idea to treat coronary disease. And domestic BRS are more effective and safer than abort BVS. We knew lessons from absorbed serial studies, and we can do more to promote vessel recovery therapy. And BRS, of course, BRS is not something one fits all. Limitations are obvious. It cannot be used in left main lesions, CTO lesions, and bifurcation lesions. Real-world cases are challenging to BRS. Thank you.